We're gonna talk about secondary prevention, and then we're gonna get into stroke centers and units, and then I'm gonna follow up with some recommendations on how I would recommend you look at the test and how to anticipate questions and that kind of stuff. So we'll follow up with that, and then we will be done. All the main stuff, there's still a lot going on that we have to talk about. In terms of complications, one of the big complications of anybody in hospitalization is venous thromboembolism. And we have this, obviously a high risk of DVT, pulmonary embolism, and related to DVT, that post-thrombotic syndrome that they can develop. It's considered one of the most preventable causes of death in hospitalized or recently hospitalized patients. Interestingly enough, there are millions of patients who develop a hospital-acquired VTE within 30 days of admission. And of these, quite a significant number, 1 out of 100 die from the complications, okay? Unrecognized VTE is a common cause of malpractice claims. I'll never forget, I went to go see a patient who had been in the hospital, been in ICU, and was over in rehab, like behavioral rehab, on the psych floor, and he had a bunch of leg pain. So I go over there and I see him, and there's no swelling, there's nothing like that, and so I just think maybe this is a sciatica or something. He had no indication that he had a DVT, and so I treated him with steroids. Went back about 24 hours later, they had discharged him, and I was like, I need to find out because I was a little bit concerned about this leg. And making sure that he shouldn't respond to steroids. If he didn't respond to steroids, I was going to do an ultrasound. And his stepmother answered the phone, and I asked her. I said, "How's his legs?" I said, "I want him back in the ER." And of course he had a DVT. So it's one of those things where that taught me as a young nurse practitioner have a low threshold for recommending ultrasound. I mean, I can order it, but from a staff perspective, recognizing that. Obviously, a lot of cost associated with that, but again, the highest cost is in a life or disability. PD is killer. I think we all, it can be. In the United States, it kills more people than HIV and AIDS and breast cancer combined. It's associated with 10% of hospital deaths. Okay, and is responsible for approximately 10% of all acute stroke deaths. Only about 1% of patients will be really symptomatic with it, and about 50% of untreated DVTs will progress to PE. Obviously, most of them occur without any warning signs or symptoms, and quite a large majority of them are diagnosed first at autopsy. Which, do y'all do many autopsies here? I find it interesting, we don't do very many autopsies.
Yeah, I mean, we have coroner's criteria, and then there's a family request process, but like the family request is rare because it's not covered by the hospital or the state.
Yeah, exactly. Yeah, ours is too, as well. So these are, these are autopsies for other reasons, right?
Does Idaho like death within 24 hours of mission, like requirement for?
Within 24 hours of admission, yeah, that's one of the criteria, or any like patient arrives unconscious and never regains consciousness is another one. Like there's a pretty, it's not extensive, but it's a pretty big list of criteria that people can meet.
Can be for the coroner, yeah.
Mm-hmm.
I always find it interesting for the criteria for the coroners. I mean, this is totally down an alleyway, but like in our state, the criteria for coroners, you have to take a course and you have to be 18 in some areas, and I'm like, some of them are like EMTs, some of them are like funeral home directors. I mean, I always think you don't have to be a medical person necessarily to be a coroner. And I always think that's kind of crazy. Okay, getting back to our regularly scheduled program. For DVT, obviously this triad, this Virchow's triad, you will probably see again. But again, the risk for a DVT is really defined by this particular triad of the change in the vessel wall or injury, change in the pattern of blood flow, venous stasis, or a change in the constituency of the blood, hypercoagulable states being one of them. DVT is almost, can be clinically silent, and most often is. And again, that PE is one of the most commonly misdiagnosed. Very few people examine the legs in detail. Your staff is gonna notice swelling before anybody else will, because, they don't look at their legs, honestly. And this is really important to know. The Homan sign is absent in over 50% of cases. I was taught that in nursing school. Always do the Homan sign. It's absent in about 50% of cases. And so, so again, you have to look further into that if you suspect a DVT in the lower, in any extremity, really. I'm seeing a lot more upper extremity DVTs because of our use of PICC lines and things like, I don't know if you're seeing that, but I'm seeing a whole lot more of upper extremity DVTs than I saw earlier in my career, because it seems to be related to PICC lines, I don't know. All right, risk factors for VTE. Anything limiting physical mobility, and it can be cardiac, respiratory, it can be a deficit of some sort, atrial fib or flutter. Again, anything that limits that mobility. Personal or family history, so DVT or pulmonary embolism. For some reason, administration of platelets due to that platelet aggregation. Obesity with a BMI greater than 25, and again, impacting the mobility. Smoking combined with oral contraceptives or hormone replacement therapy is a big one. We can't forget our pregnant women, because our pregnant women are hypercoag. And so within a month postpartum, they are at high risk for a clot. Any kind of cancer or malignancy, again, puts them in a hypercoagulable condition. Thrombophilias and sort of an older age group. They typically don't happen in a younger age group, but they can certainly come. Okay. You know, previously lower limb DVT was much more prevalent than upper extremity limb DVT, and that's still true. I'm just seeing more incidents of the upper limbs, and so if you have an upper extremity that is swelling, you might want to think, hey, do I have a clot in here? Post-thrombotic syndrome is really common, even after you resolve a lower leg DVT. And so you get these abnormalities from this venous distension. And again, those veins, you know, they're not real elastic, and so they don't bounce back really well. So these patients can have chronic leg pain, swelling, dermatitis, even leg ulcers, okay? And again, they can also have another DVT. So again, this would be with the edema that happens with these patients. This would be a patient that you could consider like TED hose or something like that to prevent the edema, but you gotta watch the skin with those things. Okay, how do you prevent it? Graduated compression stockings, TED hose, okay, are not appropriate prophylaxis to prevent a DVT. How many of you ever put on a pair of TED hose? Yeah. The elastic at the top is really bad. I mean, I end up taking a pair of scissors and cutting the elastic at the top, to be honest, and I think that may diminish the effectiveness of them, but the stocking kinks can reduce arterial inflow and venous outflow and actually complicate your picture. Again, inferior protection when compared to sequentials, and their real utility is in prevention of post-thrombotic syndrome after DVT. But when I fly in airplanes, for whatever reason, my feet swell, and I put them on when I fly to prevent that. When we look at sequential compression devices, the CLOTS 3 trial found that the sequentials reduced the risk of DVT much more significantly than those TED hose, okay? So we put those on everybody in our unit, especially with hemorrhagic patients, but we put them on everyone. And again, if they're receiving unfractionated heparin or low molecular weight heparin like enoxaparin, you don't necessarily have to have them, but if my patient is immobile, we're probably gonna do both. because of the high risk of those patients. Okay, do y'all do both?
Sometimes.
If they're ambulatory and we're doing prophylaxis anyway, it's a tripping hazard for them. You know, I mean, that's the other thing you have to, because you tied them to the bottom of the bed, basically.
Right.
Yeah. Unfractionated heparin, just regular heparin, affects many points in the clotting cascade. It's cheap, and it has a short half-life, so we can initiate that pretty safely in most stroke patients early. The limitation on this is that it's protein bound, and that may make the dose sort of unpredictable across different people. And again, it may also contribute to heparin-induced thrombocytopenia. What I would say is 5,000 units every 12 hours for moderate risk. The trauma guidelines will tell you that's not a prophylactic dose, just FYI. The same dose at every 8 hours for high risk. All of our patients are high risk, to be honest, okay? The low molecular weight heparins are more predictable dose response, and you don't really, I mean, you don't have a good way of monitoring, but you don't need to either. Has a longer half-life, that's the reason why it's once a day dosing, which is nice for your patients. So, again, fewer effects on the platelets, so you don't have the concern for thrombocytopenia. And again, it's a daily dose, which is nicer for your patients. They're tired of us sticking them, to be honest, okay? What do y'all do for the surgeries? Do y'all use heparin or Lovenox?
Both.
Use both? Do you
I mean,
use
either or.
Lovenox? Yeah,
Either or, just depends on the provider.
okay, yeah. Some of the newer ones realize that using Lovenox doesn't increase their risk for bleeding. Some of my older neurosurgeons are still on heparin, and so it's hard to get them to switch. They're doing a Q8 dose, but it's still hard to get them to switch to that.
Do you see
Yeah.
any preference for the, like, just the unfractionated, just because it's more reversible, or?
Yeah, and I think it's a more short, it's
Yeah.
a shorter half-life.
I mean, for us, a lot of times if they do want to, sometimes they'll just start a drip, cause they can turn off the drip like a couple hours before surgery and be good.
Oh, yeah, and so, yeah, so if it's something that we need to do when we're bridging,
Yeah.
we'll do something like that,
Mhm.
yep. Yeah, we will, but for, yeah, if we're having to bridge, someone, then we'll definitely do a drip. And we do anti-10A, so we don't do like the PTTs anymore, y'all do anti-10A?
Yeah.
We do too. Yeah, again, part of that is making sure that you're measuring what you think you're measuring, and the anti-10A does it better. Yep. Ultrasound is highly sensitive and highly specific. Okay, so ultrasound, you know, obviously if you have a swollen leg or a painful leg, very sensitive, high specificity. It is user dependent, but a lot of your ultrasound techs are very savvy in how to detect these. If you get, if you have a more proximal clot, that, you know, it can be a little challenging, and it's you really don't have an ability to differentiate clot age, so you don't know if it's chronic or acute, you know it's there. The D-dimer is non-specific to location, and I'm gonna tell you for my patient population, because I have blood in the head or something, the D-dimer is always gonna be positive, so D-dimer for us is like not real helpful. Post-op is gonna be, you know, elevated, and so if they come in through the ER and they're worried about it, a negative D-dimer rules out the DVT. But again, in our patient population, we're doing so many things to them that that it makes it hard to use just a D-dimer. You can also use venography. It's similar in sensitivity and specificity to ultrasound, but it is capable of looking distal to the inguinal ligament, which can be hard to see sometimes in with ultrasound. But you can get with any CT, you get artifact. And so, again, you may not see what you want to see, and you have to use contrast as well, okay? MRI, when you have vena cava thrombosis, MRI is really where you want to go, because you can't get there, obviously, with ultrasound. It's a little bit difficult. And so if you have an iliac vein or inferior vena cava, MRI is really a good route to go. Okay. These are the ASAP guidelines. Acute low molecular weight heparin is preferred over unfractionated heparin because you have the predictability of the response and less need for monitoring. You can use those compression stockings again to prevent that post-thrombotic syndrome for at least a year after the diagnosis. Anticoagulation should be maintained for 3 to 6 months after the first DVT and more than a year for a recurrent one, okay? And again, we're using more apixaban in these particular patients over warfarin. Okay. IVC filters. We don't put a whole lot of IVC filters in. Sometimes we have to, if they have a large burden of clot and I can't anticoagulate them, sometimes we'll put them in, but not routinely. And honestly, they should be reserved for patients with an active DVT that can't be treated, so you don't prophylax or anything like that. The filter occlusion may be as high as 67% by 9 years, so we're using retrievable filters, obviously. You want to use get them on anticoagulant as soon as possible when you can with these particular patients. But again, they're typically used for high-risk patients, for PE, and patients you can't anticoagulate, okay? We use these, I use this mostly in trauma, not so much in stroke, because I can always start something. But again, being attentive to different options we can use to prevent PE. Let's talk about dysphagia and nutrition management, just a little bit. Okay. People don't realize how many muscles are involved in the head and neck that have to interact to affect a swallow. It's a bunch of them. So if you remember that motor strip and an MCA stroke, it affects all of those muscles. And so, so being very attentive to swallowing is important. But dysphagia is defined as any impairment in any part of the swallowing process. And there's different types. There's like oral dysphagia or pharyngeal dysphagia. So the speech therapists come in and they really look at that impairment. It's estimated to affect about 2/3 of stroke patients. And of those, close to 20% will require tube feeding for some period of time or permanently. And that's not news to you. We also may have people who are silent aspirators, may occur up into 50% of those cases. What swallow study do you use? There's like GUS, there's like
The barium swallow study.
Use which one?
Barium.
Mm-hmm. Yeah, the speech therapy. What do you use at the bedside?
What are the options? I can't remember.
I mean, we follow that, like.
Is it like a water swallow test? Where you do a water?
It progresses to it, like you do orientation first, then you have them cough, you have them smile, you have
Yeah.
them swallow dry, if their
Okay.
voice is clear.
Gotcha, okay. And so the main thing is that you have one and that you know how to use it and you use it correctly, because there's not a single bedside method that makes your bedside assessment have a high degree of accuracy, okay? And you don't have one method that will guarantee a patient won't aspirate, okay? So the main thing is you have a screening tool and you know how to use it and you're actually using it. Like I said yesterday, you know, I had a low threshold in the ER for like NPO. Sometimes in the ER it can be really difficult to do a full assessment, and when they get back to the unit, then you can repeat that again.
We use modified Maxi, sorry, I just.
You do the
Thank
modified,
you.
you do the modified, you do the modified.
Modified Maxi.
Okay, yeah.
It's like it has a-
Yeah, different people use different tests, and the main thing is that you know how to use it, you're using it consistently, and you're doing it and documenting it before you give an oral med. That's the main thing, okay? One of the things, do you have a protocol that either allows pharmacy to convert the oral meds? Do you have a protocol like that?
Yeah.
Yeah.
Yeah, we do too. Yeah. It helps a lot. So as soon as pharmacy recognizes their NPO, pharmacy does it on their own. I don't need the nurse involved at all. The main thing, so I don't know, this might be a good question. The most common site in the hospital for violation of MPO status with or without documented bedside swallow is the ED.
Yep.
It's ED. Okay, sorry, ED. Again, I'm not gonna go through this, but the main thing here is that patients will wax and wane in their mental status, and speech will clear them for a diet, and I will walk in and they will be too sleepy to even interact with me. And those are patients that go, well, they passed their swallow, and I was like, but they can't support their nutrition. And so trying to help families understand that is important too. So just, having them recognize that, we need some assistance in the short term, to enable them to get the nutrition and the hydration they need. I think that's a good conversation to have. We use that, the barium swallow as well. This is, the FEES testing. The speech language pathologist can do this at the bedside. Typically, we go down and we do barium down in x-ray. But the FEES provides, evidence that the substances are actually not going into the lungs. Okay. Now the main thing is you can imagine, you're maximally stimulating this patient, and so you can have false confidence that this patient is actually okay when really they're not. And so that patient looks pretty awake. The other thing I will do is I will hold off on speech doing a formal assessment when I know they're not gonna pass it, And so, so people will be pushing for the speech therapist to push that barium swallow, and I'm like, they're not awake enough to do that. So we have we put in quite a few G-tubes because of that while they're getting ready for all of that. So that's, again, another, thing to do. Obviously, ahead of bed, 30 to 45 during continuous feeds. Wakefulness when they're actually eating, and making sure that we have people who have dentures. I know you do too. And making sure that we have those dentures with us. Sometimes we don't, and we have to adjust their consistencies. Oral hygiene, I don't know about you, but I know we think we do a good job on oral hygiene in the ICU. We don't. We do not. I have walked in off shift and I was like, has anybody done their oral hygiene the entire time they've been here? I mean, anybody? And so oral hygiene is really also important, to kind of clear that bacteria and just make sure that get their mouth clean. Chlorhexidine has been associated with reduction. I know you have probably bundles, like ventilator bundles. Is chlorhexidine probably one of them?
We switched to hydrogen peroxide.
Okay.
I think though.
Okay.
because it would-
Okay. Yeah, there's no
It
data
has
for.
it has a longer kill time too.
Is it the peroxide does?
That's what I think that's what the evidence was saying.
Yeah.
I think we still use chlorhexidine,
Mhm.
but I can't remember if we made the official switch or not.
Yeah.
But
We were talking
I'm in the
about it.
oral care kits still.
Yeah, I mean, it goes to show you that you may have evidence today, but tomorrow it changes. Okay, so again, there's no data, in terms of stroke patients specifically, as far as chlorhexidine.
To hydroperoxide.
Okay, the one thing, we all know how to place a NG tube, we all know that. Yeah, we're gonna auscultate during air insufflation. Testing the pH is not a good way to know that you're in. The visual inspection of the aspirate is not a good way. Even the presence of the carbon dioxide in the tube, it's always gonna be, X-ray, okay, is the most valid and most reliable way. I've seen these things where, do y'all have a mechanism where when you put the tube down, you know immediately if it's down? Do y'all have that? Okay. I mean, I've only seen these at trade shows. I don't know that people actually do them. Probably, at the end of the day, getting an X-ray is cheaper than having something like that. But the most reliable and valid method. We've all seen pictures of the NG tube in the brain when we were in nursing school.
Are you talking about the NGs that have the glowing dot at the end of the guide wire, and then you have the
Yeah,
the,
yeah, well, it's not the Dopphoff, but
it's, but yeah, you can tell where it's at when you
Yeah.
put it down before you pull the thing.
yeah, it's something like
We
that.
don't
It's
have
a-
that here, but
yeah.
I've
But
used it.
you've seen it, yeah, yeah. Yeah, it's like that, and then that way you know you're down.
Yeah,
Yep, a lot, and,
They're cool.
I haven't run into anywhere, that, yeah, it's pretty cool.
yeah.
Yeah, pretty cool, yeah. Again, post-pyloric tubes, obviously those risk for aspiration because it's below the sphincter. And continuous feeding carries less risk of aspiration than bolus feeding because you're given smaller amounts. I don't feel like I need to talk to you about assessments about the length and how to put that in.
Does your hospital do the post-pyloric tubes?
We do occasionally.
Okay.
Our go-to is just gonna be an NG.
Okay.
It's gonna be an NG, and if I have trouble with like nausea, or I have trouble with them not tolerating the feed, then we'll float it. Then we'll float it to post-pyloric.
I just read a study about this the study was more about training nurses how to confirm with ultrasound the
Yeah.
placement because they were having a lot of x-ray delays, which isn't a huge issue for us in the hospital.
Right, yeah. Yeah, if you're having a lot of X-ray delays, then you know, you really are, especially when you need that, when you need to put something down that tube, okay? Again, maintaining that head of bed position. And I need somebody to remind, do y'all know about the Zodiac trial? Okay, somebody put that on your list, cause I wanna talk to you about the Zodiac trial before I get out of here, okay? Cause if anything for sure that I think might be on that test, that would be.
What, they find a killer?
No.
Taking them to trial?
No, not that I know of. Okay. All right, in terms of formulas, we let our dietary teams, take over this. But again, what kills me is when I have a patient that came in on Friday and they've been NPO all weekend and we haven't done anything about their nutrition. And I come in on Monday morning and they're like, well, they're NPO, and I was like,
And they don't have fluids going?
we have nothing. We had like 0. And I was like, Okay, so typically, we need to start these things and get these things going, okay? Again, most people can tolerate, rates, pretty good rates. Most people can. And trying to work with your dietary teams, I'm being a little bit more aggressive and not just waiting. The other thing too is the diarrhea. They go, oh, well, they just have diarrhea. I know, it's like, okay, well, do something about it. I mean, call dietary. I mean, we can put in Gorgum. You can do things to deal with diarrhea. You shouldn't accept that as a normal. And again, if you're worried about C. diff, I think most people know what C. diff smells like. And so, I think most people don't have a.
Studies have shown that nurses are unable to identify C. diff by smell.
I'm sure.
But
it's
we
culture.
totally can.
Yeah, I know, yeah, so, again, low threshold for seeing that if you need to. Okay, aspiration pneumonia. Now, here's what I will tell you. So the reason why I bring up Zodiac trial, because the Zodiac trial was a trial, and actually Ann did it, and it was a lot of people across the country participated in that trial, and it was a head of bed flat trial that in patients with large vessel occlusion who are waiting on transfer or waiting on thrombectomy. So they didn't elevate the head of bed flat for those patients. And in order to get through IRB, you have to say that you're not gonna do any harm to the patients with this intervention. And so she had to look at aspiration pneumonia risk. And so what she looked at in order to get that trial approved and through IRB is she looked at aspiration pneumonia and the fact that our definitions lack validity, reliability. Hospital-acquired pneumonia is used to define what probably is aspiration-related, okay? And hospital-acquired pneumonia has a definition, okay? So it's the onset of a new or progressive infiltrate on pulmonary imaging, but you have to have 2 other things that go with it. You have to have fever purulent sputum, leukocytosis, or decline in oxygenation. And what she found was aspiration pneumonia is commonly used in the records, but they don't meet the criteria. So when she was doing the pilot study to the Zodiac trial, 20% of patient records documented the use of the term aspiration pneumonia, but only 4.5% actually met the pneumonia diagnostic criteria. And so, so interesting that we sort of overcall that a little bit. But again, we don't put food coloring in the tube. There's nothing to test from the lungs, okay? Both of those things are test positive for glucose if we're gonna do that. So again, pneumonia has a very specific definition. It is a hospital-acquired condition, and so you don't want especially your ventilator patients to develop a pneumonia. So doing all those things, oral care, head of bed, and all that kind of stuff. But when Ann was doing the Zodiac trial and doing head of bed flat, she had to address this. And all of her patients in that particular trial, none of them developed a pneumonia with head of bed flat, and patients who had a large vessel occlusion who were waiting on thrombectomy. So it's not a treatment, it's a maneuver in order to reduce the risk of neurologic decline while you're waiting on that definitive treatment, thrombectomy.
Increases.
Huh?
Just increased perfusion.
It does. And so we used to use that a lot, but then we're worried about pneumonia. And so she had to prove in her pilot trial that she wasn't gonna increase the rates of pneumonia before she did her IRB trial.
In these patients, assuming how long they're waiting, what are we doing for nutrition? Are we doing those post-pep?
Well, so for those patients who are waiting, it's short-term.
Short-term head of bed flat.
Yeah, short-term head of bed flat. You're waiting on thrombectomy. This could be in your acute stroke ready hospitals when you know you have a large vessel occlusion. You're gonna leave them flat, and then you're gonna get to your destination. It's a rescue maneuver, really. But they had significant differences and reductions in the neuro decline of those patients compared to head of bed up. And she said, so our assumption is that head of bed flat increases the pneumonia in those large vessel occlusion patients. But that's sort of an aside, but I wanted to bring it up because we bring it up in here in this slide, okay? But she did have to look at that. So let's look at stress prophylaxis. Stress ulcers are common in patients hospitalized, okay? It's a common sort of requirement to make sure that we look at the criteria for those patients. ICU patients, typically we're giving them Pepcid or something like that. But again, any sort of admission requiring resuscitation or in a critical care setting. Now I have some of my intensivists will write in their notes, no strong indication for SUP, that's stress ulcer prophylaxis. Because they don't have any criteria where you really need, even though they're in the critical care unit. Okay? So again, just addressing it. So what are we gonna use? Okay, proton pump inhibitors, H2 blockers, and antacids. So the proton pump inhibitors end commonly with the letter ZOL, like omeprazole, lansoprazole, pantoprazole, okay? We don't use Nexium much anymore. When we look at patients who are on Plavix, clopidogrel, there's some suggestion that you should avoid the proton pump inhibitors. It's a little bit mixed, but in the hospital we do avoid them. The H2 blockers end in dyne, ranitidine, famotidine, cimetidine, and so we use mostly famotidine in the inpatient, okay? Long-term use has been associated with gastric cancers, but we're not using them for long-term use. We're just using them for right now, okay? You can give antacids. On the floor. Do you want a Tums? Sure. You know, we don't use that in the unit. Again, long-term use should be avoided, okay? When we start their feeding, typically that helps reduce their risk of stress ulcers. And so you typically don't need them when you're starting the feedings because the stomach has something. The stomach is not churning in its own acid, okay? Alright. So, moving on to bowel and bladder management, we're almost done. Constipation, I can't tell you how many times I've gone on the unit and the nurses go, they haven't pooped in 10 days. And I'm just like, and why are we just now bringing this up? Anyway, it's often brought on by dehydration in our stroke patients. Many of them are dehydrated on admission, but certainly our MPO status and then no hydration doesn't help that. My experience with tube feeding is that it promotes diarrhea, not constipating. We do supplement water with them, and again, fiber-containing formulas can be helpful, okay? So constipation is a real issue in our units. UTI, particularly as it relates to catheter, CAUTIs are a never event. But incontinence can occur in as many as 60% of our stroke patients, okay? Despite that, we use PureWicks and we use external catheters if we can. But let me say this: you need a catheter if you need a high reliability in your output, especially if you have cerebral salt wasting or something like that in your aneurysmal patients. You do need a catheter for that. The other thing that I would say is, you know, patients with stroke can also have a neurogenic bladder. You know, and so the bladder is a muscle just like anything else. And I always, I tell the nurses, have a low threshold for a bladder scan, because their incontinence could be overflow from, you know, basically having a distended bladder because they can't urinate. So I have a low threshold. When somebody says, well, they're just incontinent and do we bladder scan them? You know, and that may be the cause of their incontinence. So have a low threshold for that, okay?
I can't remember, do we need an order for bladder scan?
No,
Okay.
I mean, we bladder scan everybody all the time. I mean, we have 3 bladder scanners for a 34 bed unit. If that tells you anything.
Yeah.
And we're always.
Yeah, that should be, yeah, if you need to order to bladder scan somebody, boy, I mean, we need to take that back.
Yeah, no, but just straight cath, then,
Yeah.
I mean, obviously, but
Right.
we have no problem.
Yeah, and I'm surprised about how many nurses will call me. They don't even think about the bladder scan. They just put the PureWick on them or whatever, and try to hold that in place. But they don't even think about bladder scanning them, and they'll call me and they go, Rhonda, they have 800 in their bladder, and I was like, yeah.
No, we're a little obsessive about bladder scanning.
I know,
mean,
that's
but it's
good.
good because we
That's
catch
good.
a lot of
You catch a lot of that
stuff,
stuff.
and we straight cath people so much.
Yes, well, that's good.
Well, I mean, it's stroke, but it's also neurosurgery, so you're dealing with
You're
like
dealing with all the things,
all the
spinal cord,
things.
all the things.
Yeah.
Well, a lot of people baseline will just retain, so that even if they're pink, doesn't mean they're not
Mhm.
retaining.
right.
Exactly, yeah. So have a low threshold and mobility. This may be let's talk about mobility, because, you know, when we mobilize patients, we do have a reduction in our complications, right? If they're immobilized early. But the problem is in our stroke patients, it's a perfusion problem that we have to address. And so it's more like an MI than it is to anything else in the neuro world. And so many mobility protocols start at 24 hours after admission or later. And so the problem with that is we didn't know how early to mobilize and how often to mobilize. And so that data did not come out until Julie Barnhart's work in the AVERT trial about 10 years ago. So we talk about early mobilization of stroke. It was first talked about in the 1980s in Sweden. Dr. Andradovic and his colleagues, he's a neurologist in Norway, and he reported a decrease in death and disability when they started this early rehab program because it was mobilizing people. So they didn't die of the complications that we just talked about, pneumonias and blood clots, that kind of stuff. But we really didn't have a randomized controlled trial, and so the AVERT trial was done, and it took 10 years to get the data. So they did this, a long study over 10 years. And so there's 2 of them. One was Sunseth's work and that was back in 2012. And these were very early mobilization, and patients showed a trend toward poor outcomes. Okay, and then the AVERT trial had on these very early mobility patients, fewer of them had good outcomes. And so death associated with neurologic deterioration or recurrent stroke in the very early mobility group was significantly higher. So that's why in your order sets, PT won't see your patients within the first 24 hours. It's based on this AVERT trial of saying this very early mobility within the first 24 hours could actually do harm to those patients. And so slower mobilization occurring beyond was associated, 24 hours was associated with higher favorable outcome at 90 days, but very early mobilization within 24 hours had a number needed to harm of 25. So for every 25 patients over that time period that you got up within 24 hours, one of them was harmed. Okay, so 4 out of 100, 4% was harmed. Okay, so that's why.
Are you comparing those two?
Huh?
With the slow?
Yeah, slower mobilization after 24 hours was associated with more favorable outcomes. But or very early mobility defined within the first 24 hours is harmful, or is associated with harm.
Just that verbiage, number needed to harm.
Yep, the number needed to harm is 25.
Okay.
Yeah, does that, so for every 25 patients that was in this very early mobility group, one was harmed.
Okay.
Yeah, does that mean, that's how you read that number?
And by harm, they're defining an outcome at 90 days, not like the patient tripped or something and
Right.
bumped their elbow.
Yeah, they're using the modified Rankin.
Okay.
Yep. And her group is still into rehab and things like that. Okay. So in acute stroke, evidence supports a rested approach within the first 24 hours, and that's a strong recommendation, high quality of evidence. So similar to MI, acute stroke warrants a more guarded approach to mobility, especially in the first 24 hours. And we still don't know the optimal dose and timing, and whether it differs by stroke subtype. I mean, does it matter if your patient had an NIH of 1 or 25? I mean, intuitively, it would seem like it would, right? And so the phase 2 clinical trial is going to look at some of that, so that we understand which patients might benefit. Because honestly, the person who comes in, we thrombolyse them, and they're doing well, and they have a really low NIH. Is that a patient that we could get up? You know what I mean? Versus some of the other patients. So I don't know, we just don't know. And again, looking more at the dose. Okay, and the neuro ICU. In our mobility work, there's not been a good way to look at that. There's a lot of bias in some of the studies. A lot of these protocols were performed as quality improvement. And when you have quality improvement protocols like that, you don't have IRB oversight, and you have a mix. In the neuro ICU, you don't just have stroke patients. You've got, neurosurgery patients. You've got, hopefully your trauma patients go to a trauma unit, but you've got a mix of neuro, you got brain tumors, you got all kinds of stuff. Okay. Victoria Swansel did a very interesting study, and she was like, we put these orders in for mobility, and these patients aren't getting up. And so actually, it was recently published, even though she had done this some time ago. But anyway, but she looked at over 300 stroke unit patients with orders for mobility. And what she found was that the number of patients assigned per nurse and the NIH score, in other words, were they dependent, were independent predictors of time out of bed. And so if they had a lower nurse-patient ratio, those patients were up significantly more than if those nurses had a higher nurse-patient ratio. So anyway, so it's interesting. It was the first study that we'd seen about staffing and mobility in patients.
Makes sense, but I mean, I
Yeah.
guess some people need to see it on paper.
Well, some people needed to see it on paper, and some of the you know, some of the work that, was done subsequently was about nurse staffing. And say, if you want if you want to reduce complications in patients, you have to invest in your nursing staff. I mean, you know, it's fine to have, you know, nice equipment and all those things, but you've gotta invest in your people.
Well,
Yeah.
AI is not gonna get a patient up.
We're 3 to 4, depending on acuity,
Yeah.
up on just the neuroscience unit
Mm-hmm.
along, I mean, which,
Yeah, and a lot of times, even in
is
my
awesome.
ICU, well, that's great. A lot of times in my ICU, they end up getting tripled. I mean, it's in an ICU. And so it's a real problem, and when you're like, you know what, if you can't be competitive, you know, but if you wanna reduce complications, you gotta deal with your staffing.
Yeah.
So that's great that you have that. Yeah, that's great that you have that.
Way back. Yeah, we haven't done that.
Okay, pressure ulcers, I think this is the last part of this, okay? Again, obviously due to immobility, right? Hospital-acquired pressure ulcers are in the billions of dollars. It is a, sort of a never event. Again, looking at risk assessment, what do y'all use do y'all use Braden scale? Yeah, we do too, yeah. So it's designed for use by nurses to assist in prediction of pressure, of the risk. Very little time to complete, and, is really generalizable across settings. Okay. And you all know, because you use it, the Braden scale, you know what the sort of the factors are here. And when we look at all of those things, obviously lower numbers, very high risk. And that number can change. Now, what our regulatory bodies say is that they're not defining what we use, but they do want us to use a standardized scale, and they do want us to use bundles. And so those bundles, involve assessment, turning, nutrition, head of bed, less than 30, incontinence care, obviously, and pressure relief, okay? Falls are really common too. And so we get called a lot on the neuro floor for falls. And so of course, organizations have instituted fall prevention teams, or rounding teams. What do you need? Because a lot of times people fall because they're trying to get something. The other thing, the reason why they fall is they forget that they have a deficit, particularly with the right hemispheric insults, because they have those deficits and neglect on the left side. And a lot of times these older people, they do not want to pee in the bed. They do not. And when we go, oh, well, you just go ahead and go, they've been told their whole life not to do that. And so it's really difficult for them. So again, having those rounding teams can be really helpful. It's really terrible when we have a hip fracture or some sort of injury related to that, but it's most commonly on the paretic side. And again, prevention measures, the bed alarms, making those rounds, making sure that you're offering the bathroom, that kind of stuff. Okay. Yeah. Okay, complication. That's complication prevention. A lot of the things.